I think we are live.
Yeah. So hello everyone for yet another session of Fertility Masterclass. Today's session is a very practical one, which I think every IVF consultant across the globe would have faced this situation. And fertility services are getting more and more competitive, and as patients are becoming more and more educated and aware with so much information on the digital platforms which are available. So I think it becomes difficult for an IVF consultant sometimes to counsel or to tackle the problems of negative results in an IVF in spite of thorough counseling. And after a negative result, I think one more most frustrating and most challenging situation an IVF consultant faces is when there are poor quality embryos which are formed, or when there are no embryos which are formed. So I think we should have a set protocol as to how we can tackle this in our day-to-day practice so that it becomes easier for every IVF consultant who can standardize this and not feel guilty about the whole situation in front of the patient. So I think Dr. J has immense experience in dealing with this, as he is one of those referral IVF centers who tackles these kind of problems day in and day out. So over to you, sir. You can take over.
So I really wish nobody gets an experience of handling these cases, because when somebody forms poor quality embryos, it is not a very pleasant situation, as you already mentioned. But I think when you have poor quality embryos, there is a beautiful objective assessment which you can do, and I think I'll just share that. It's going to be a short class, but I think it gives a lot of value added information. Okay, so I'll just share the screen. Uh, See if you can see the screen.
Yeah.
Okay, all right, fine. So basically, we are trying to deal with poor quality of embryos. Okay, now very important for us to understand, when we say poor quality embryos, what exactly are we trying to say? So basically, we are trying to also talk of arrested embryos in this, right? Now, in your arrested embryos, okay, you have multiple things where you can actually draw a good flow chart and try and make people understand. So I have this thing in my training for embryologists when we take this training, and for all the people who have been trained under me, and it gives a very nice sort of a protocol. Okay, so the first thing is fertilization failure. Okay, this is the first thing. Second is day 3 embryos poor quality, day 4 embryos poor quality, day 5 embryos poor quality. Okay, so it can either be day 3 embryos which are fragmented, right? It can either be day 4 which is arrested, or it can be day 5 poor cavity. All right, now please understand, apart from fertilization failure, all these other three come in the category of morphological assessment of your embryo. Okay, basically, the thing about fertilization failure, which we have to keep in mind in today's time and age, was it IVF failure or was it ICSI-IMSI failure? If it is an IVF failure, then usually it is a technique which has gone wrong. Okay, and mostly the technique which has gone wrong is the technique of semen preparation. Okay, please keep this in mind. Very important again, as far as ICSI and IMSI is concerned, is that if ICSI and IMSI has failed, it usually indicates poor sperm poor egg, and granular cytoplasm especially. Okay, see, the thing is, when you do ICSI and the cytoplasm is unable to pack the sperm, that is when it usually gives rise to a fertilization failure. If the technique of doing ICSI is going to be poor, okay, then usually it will not cause fertilization failure. It will cause the oocyte to degenerate. The oocyte will become black. Okay, so just keep that in mind. Very, very important for things to note, especially when it is IVF. Okay, the most important thing which matters in IVF is case selection. Okay, kindly do IVF nicely for patients and try to ensure that the total motile sperm concentrate with which you are trying to do IVF is for beginners at least going to be more than 5 million. Okay, just keep this in mind. For lower sperm qualities, it is important to understand that when you are doing IVF, you may have some fertilization issues if your technique is not correct. IVF is a technique driven game, okay, because you are depending on nature. So, this is your primary assessment when you look at the file of the patient. Now, obviously, common factors, okay, in all this Ram Katha, there is a common factor which you are supposed to look as far as the female is concerned. AMH, more important than AMH is obviously the age. These are the female factors which you need to see, and you need to look at the antral follicle count. In a country like India, very, very important to also ensure protocol and drugs which have been used. Okay, in India, this is something which is very, very important. If you're looking at male factor on the evaluation of the file of the patient, it is important that for male parameters, you try to look at DNA fragmentation index. You try to look at specifically non-obstructive agiospermia. Okay, because all these things can give rise to formation of fertilization failures, poor quality embryos on day 3 and poor quality day 5. Okay, but these are your standard things. You're supposed to look at female, you're supposed to look at the male. Also, very, very important when you try to say poor quality embryos and if fertilization failure has been taken off the market. So that means this part has been taken for day 3, day 4, and day 5. Laboratory quality. No notes are available regarding laboratory quality. So I'm just putting a star mark to this because this is something you can't really assess. Okay. But please look at culture conditions. And in culture conditions, let me tell you that benchtop is giving the same results as box type incubators. So don't worry about that. Sequential media is going to give you the same outcomes as single step media. So just in case notes are mentioned about that, don't worry about that as well. All right. The biggest problem when an embryo undergoes an arrest at day 3, so I'm just drawing that embryo, is going to be this. You will see this, and probably once you look at this picture, you will realize everything. The first indication that this embryo will be arrested is going to be visible to you actually on day 2, and that indication is unequal blastomeres. Okay, so if something like this has been mentioned, especially if the image of the embryo has been provided, okay, many a times what happens is in poor AMH patients, when AMH is very low, you will have an unequal blastomere formation on day 3, and the clinician would insert this embryo inside the patient, stating that, Array, you formed embryos, what is the reason to worry? Just go ahead and implant them. But if the image is available, and if it is an unequal blastomere, remember, it is a poor quality embryo or an embryo which is going to get arrested as it goes from day 3 to day 4 and day 4 to day 5. Okay. Simultaneously, when it is a day 4 arrest, what is the problem with day 4? See this. Day 4 is when there is a genomic shift. Okay. So you basically cannot see the morula. I mean, you cannot see the number of cells, but there is one thing which is important. There is no cavity formation. The biggest problem in morula is actually your laboratory quality. Something wrong in your laboratory quality is not allowing the morula to go from day 3 to day 5. Otherwise, remember, even if there is a lab failure, embryos will go from, you know, day 2 to day 3, but going from day 3 to day 5 indicates or requires an extremely good quality of laboratory. So, predominantly, it is going to be that. Okay. And then when you come to day 5, slightly larger embryo, a poor day 5 embryo will have a thick zona. It will have a improperly formed inner cell mass. It will be loose inner cell mass, and the cavity formation will be poor. Okay, this cavity formation, which if it is poor, it usually indicates an aneuploidy in the embryo when the inner cell mass. So I'm just drawing the inner cell mass here. See, this part is the inner cell mass, and this part is the trophectoderm cell. When both of them are poor, it usually indicates aneuploidy in the embryo. It also is an indication of old age of the female partner. Okay. How you have checked all these things? So there are basically two or three important things which you should understand, which can be followed and which may give rise to better quality. Okay. As far as getting the next set of embryos which are better are concerned, and that is going to be another 5 minutes of the lecture, after which I will finish. So let's say you have a patient who has a poor quality of the embryo. So you have assessed everything. Okay. And now you are telling the patient what needs to do. Okay. So first thing, let's look at some irreversible factors. Hmm. These are factors which you cannot change. Age of the patient, AMH of the patient, usually the antral follicle count, and as far as the male partner is concerned, you can't really do much about the semen parameters if they are poor. Okay. They are very poor, you can't do much. So always look at it from this man. First, standardize your drugs. I'm telling this because this is something which is so important in a country like India. Okay, all of us know it, none of us want to accept it. Remember, in today's time and age, even if you are a corporate IVF clinic who is giving packages to the patient of 2 cycles, 3 cycles, 20 cycles, whatever, the minute you predominantly utter the word donor or third party to any educated couple, the direct result of that is doctor is changed. Okay, so if in case it is no such indication and you want to create something good, then the best option is you should standardize your drugs. Second, change your stimulation. How? Rather than standardly following, let's say you are following an antagonist protocol. Okay. You may counsel the patient for doing a random start. You may consider to add letrozole. You may consider to do a double stim. Okay, you may consider to do something like this in order to ensure that you are changing the way in which the stimulation occurs so that you may get an opportunity to get a slightly better crop of oocytes inside your batch. Okay, third important point, standardize your media. Very important point, because for people who like to use single step media, continue to use single step media. For people who like to use sequential, continues to use sequential. If you are changing your plates, ensure that the change of plates is done by the embryologist very, very nicely. Okay. Fourth, this is a point which you may consider if two or more cycles have failed, especially when there is fertilization failure for no other factors, or especially if there is an arrest at day 2 or arrest at day 3. Consider testicular sperm. Even if sperm parameters are normal, even if DNA fragmentation is normal, even if semen parameters are normal, considering and taking testicular sperms by doing a TESA is usually going to improve the quality. So the first obvious doubt is no, 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 it does not give rise to very mature sperms. Trust me, just try doing it and suddenly you will have a nice improvement in the quality. Fifth, consider to put these embryos on time lapse. Remember, time lapse does not guarantee formation of embryos, but time lapse allows you to identify the checkpoints. Okay. Once you identify the checkpoints in the patients, then you will be in a better position to tell your patient what you need to do and what not. And finally, I'll conclude with something which is an experimental therapy which we have added to our list very, very recently, and that is transvaginal ovarian drilling. Okay. Currently, TVOD, transvaginal ovarian drilling, we have tried it only in 21 patients. And so far, we've been very, very successful for patients who have had a past history of having poor quality embryos, especially poor quality embryos with a low AMH. Okay. Or with a very high AMH in cases of severe PCOS, severe PCOS. Okay. So this is what we've tried. This is what we follow. And obviously, should there be more questions to this at the end of this presentation, I shall be happy to pick up two or three questions because see, this is a big topic. Lot of questions may be there. So I shall be happy to answer few questions before we switch off.
Yeah, so AMH you said was one of the things. So what is the cutoff of AMH that you take into consideration?
Less than 1.5 AMH is considered to be low AMH as a standard. Any AMH of more than 8 or 9 is considered to be high AMH. Both these things are going to give rise to poor quality of embryos because of expected poor quality of oocytes.
And what about the age? What is the age cutoff that you think is significant?
35 is as such a standard age to try uh, to do something like this. I mean, this is a standard age cutoff, but I think in Indian women, the cutoff should be lowered for age because Indian women probably the ovaries tend to age a little faster. I think for Indian women, maybe 33 should be used, is what I think.
Okay. And what about, say, like stimulation you said, and I know you exclusively use HMG as I think, the drug of choice for stimulation across all the responders. So
Yeah,
what you change it to Rec FSH in case if the patient has not
no,
formed
no,
em-
no, no, no.
and you never mentioned the long protocol in tweaking the stimulation protocol. So you
Yeah,
don't believe in long protocol as in
not to tweak, not to tweak, because in long protocols, I think, okay, I personally think the big problem with long protocol, especially when you have poor quality embryos, is that you're causing a prolonged suppression. And when you cause a prolonged suppression, you may suppress a fresh crop of eggs, which may be stimulated and which may be the right batch of eggs. So, of course, I am not a big fan of long protocol, but I know of people who like to use it. Okay. And they may also get benefits because nowhere is it written that long protocol is inferior to any other protocol. You may consider to use the long protocol if you're using a fresh cycle.
Mm.
Okay. After all these things, but in FET only cycles, I don't think so.
Okay, so see, in many young aged women, we see
Yeah.
that it's a repetitive thing. Okay, so they come to our clinic and say that they did not form embryos in the previous center that they have gotten the treatment, and we do everything, and then again the same thing happens. So, in your experience, I mean, what is the chance that it happens again? Like, what is the incidence that it happens again? How do you counsel the patient when you take over the patient and you start the stimulation? I mean, how is it? How are you going to counsel them?
See, I think to be very, very honest, if you, if the previous guy has provided information, okay, which, many a times it is a rarity to find. Many a times you will not even find information about the stimulation protocol which has been used as far as the IVF is concerned. Finding information about the number of eggs obtained and the number of embryos formed is also a rarity, quite a lot of times. Not every center will provide this. But we are currently talking of standardized centers who are providing this. So usually when you try to go through this information, you will find something. Trust me. If you give one, if you give that 30 minutes to that file, no, you will pick up 2 points. That okay, maybe next time I'll not use this. Next time I'll not do this. Simple. Big problem in our country, very important, is I think maintenance and storage of drugs. which causes the drugs to have altered efficacy. Okay. So once the temperature control is gone, one day it is stimulated nicely, next day not stimulated nicely. Third problem commonly seen, I did not mention it, but it is very commonly seen, is an iatrogenic poor response in our country. The lady has an antral follicle count of 7. Probably instead of getting 7 eggs, you got 2. The reason why you got 2 is because you started with 112.5 recombinant FSH. So that is basically a iatrogenic poor response in stimulation, which is why I mentioned stimulation protocols are important. Right? These three, four things, if you try to modulate, you will get your one answer. Usually, when you get this one answer, I have this habit that I put these embryos on time lapse. The reason why I put them on time lapse is because patient gets a video of that embryo which is formed. And usually, even if patient, let's say out of 7 oocytes forms 1 or 2 embryos, which is standard, patient is very happy because they get a video out of it. As I mentioned, it is just a feel good factor. It doesn't increase your success rates. And even if you don't, let's say, even if you don't form an embryo, patient would really come to a conclusion as to where the embryos got arrested. Day 2, day 3, you know, morula, whatever. And I think that really helps in counseling the patient further.
So, I know that you do exclusively day five embryo transfers. Like,
Yeah,
yeah, ma many centers now have moved to only blastocyst transfers. So, you
yeah,
think this problem, like, I mean, because I think 30% of the embryos will reach blastocyst stage if at all, if everything is all right.
all
And
right.
yeah, so in case if previously, if the day three itself, the embryos have been arrested, or if it is
Hmm.
poor quality on day three itself. So, do you counsel or give the option to the patient when they come to you the subsequent cycle that you will do a day three, or you just still stick to day five and tell them that they may not even reach day five, but still you would want to do it? See, the contention here is like many people believe that the human body milieu is better. So whatever the embryo is on day three, why would you even want to give it the stress to go till day five? Why not put it in the inside the uterus and give it the best chance of implantation? So what is your take on this?
So if you ever go into how IVF is done in animal husbandry, pig, cow, all these type of things, embryos are allowed to grow till day 7, day 8. Okay. And a single embryo transfer is done. Okay. Cow can never have twins. Remember that, especially when IVF is done for them. Okay. So what is important to understand is that it is a good logic, but honestly, there is no logic. Okay. If you say that you are trying to replicate culture conditions inside the laboratory and embryo in your adjacent plate is going till day 5 and embryo for that plate is not going till day 5, okay, and your laboratory has been optimized for day 5, that means it is a patient factor. Something is wrong in some part of the patient. It could be the mitochondria of the oocyte, it could be the cytoplasm of the oocyte, it could be something into the sperm, but something is wrong. Okay. When you do, when you know that a previous day 3 arrest has occurred, again I'm telling you, don't wait for day 3. Just look at day 1 when the primary division occurs. Okay. If the primary division is occurring with an unequal blastomere, okay, usually you will have an indication that this embryo will end up with a 6 cell, 8 cell arrest, which is a day 3 arrest. Okay. No point really putting that embryo inside the patient and counting one extra ET. It's no point. Better allow the embryo to go to day 5. If it doesn't work, no problem. Try with testicular sperms. We very recently started trying with TVOD. Very recently, out of fluke. Okay. And it works very nicely by causing ovarian injury. So I think uh, probably it's the next best thing, which would come up for poor quality embryos. Change your stimulation. First time you stimulated the patient on day 2, did an antac protocol, call the patient randomly. Do a random start. Do a mid-cycle start. Something will work. Patient will form embryos. Usually they do form embryos. No need to worry.
So when do you give up and say that, I mean, definitely there is some problem de novo, either in the oocyte or in the
Three
sperm
cycles when there are no embryos.
cycles, right? Yeah. So one of our patients who came to you after two cycle failure, who want self cycle at the age of 41, so they had
Yeah.
arrested embryo. They told
They
me.
had an embryo arrest at day 3. They
Three.
gave two sites and
Hmm.
one embryo reached day 3, which got arrested. We
Hmm.
counseled them for the second stimulation. We told them the same thing, that
Hmm.
we'll go for day 5. We'll not do day 3. Correct?
Hmm. Yeah.
And they are doing it, right? So if you get two sites and you don't have a blastocyst, that's a already discussed parameter, low AMH, right? Or the age of the patient. At that age of the patient, you can't say that why you got one oocyte at age 44 and you formed zero embryos. अरे one में से तो zero बनने का is normal only, no?
Yeah. Yeah.
Correct.
No,
The
this is
problem
perfectly.
occurs
Yeah. See, this is perfectly justified. The case scenario that you mentioned, that we just had it in the last
last
month.
5 days back. Yeah,
So the problem is, like, when a young patient, like, like a 27-year-old married for 8 years and tried everything on earth and comes to you and they form poor quality embryos in spite of the semen parameters and DFI being normal. And she
yeah.
have, very like good response and very normal, like, no, the correlating E2 levels and everything like in place, and still they end up with poor quality embryos. So these become, like, extremely challenging in spite of, like, you doing similar like cycle, the number of cycles are good and the rest of them form the embryos and this patient didn't form the embryo. So you tell them about the protocol that you just mentioned, that you do this. But I think personally, I mean, if when the young patient failed to form good quality embryos, I think this may be, like, I think we need to counsel them a little more extensively, saying that this could be a recurrent problem because it could be a oocyte problem than anything else, because they're already young. That is one of the factors contributing for the unexplained infertility, as they're young, but their married life is quite long. So I don't know whether you kind of come across, because you are a
So
tertiary unit for
in 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 unexplained infertility young girls, you got 10 oocytes, but you could not form an embryo.
Hmm.
Okay, for heaven's sake, rule out PID of any form. PID due to infections, PID due to endometriosis, PID due to tuberculosis has to be ruled out. That was a, I mean, that is a common point. I did not mention it because we were discussing a technical aspect, but these three things have to be ruled out importantly in the young girls. Another important thing, if your follicle to oocyte ratio is poor, let's say you are seeing 10 follicles, you got two, or you got three oocytes. Okay, that means there is something which is either wrong in the peritoneum, or there is something which is either wrong in the drugs. If your drugs were standardized, then please consider to do a diagnostic laparoscopy before you take the patient up the second time. Take a peritoneal biopsy if you feel like something, or give a prolonged 20-day course of antibiotics to the patient, and some benefit will occur in the next cycle.
Yeah. So, so again, coming back to the similar practical situations where, how often do you do the QC of your lab? I mean, what is your interval?
I, I mean, I have not done it in the last 2 years.
How can you say that? I mean, you need to have, like, you can't, we can't extrapolate that to our thing.
No, but I think people like to do it once in 6 months.
Hmm. And do you take cultures at all from your lab?
Yeah, once in 15 days. That is a
Really?
mandatory thing because the microbiologist is very strict. I hate it, but the microbiologist is very, very strict about taking cultures, especially from the airflows.
Otherwise, you wouldn't do it at all.
No,
Okay. Hmm. Okay. So anything else you would like to add? I mean, I'm surprised that you answered it like that. Hmm.
no, but it's a fact.
Okay, coming to the time lapse, I know, I understand that it just adds for the patient satisfaction and nothing for the success rate. But in your experience with this kind of a scenario where there is a poor quality embryo in center elsewhere and they have come to you, and I know that you don't charge extra for the time lapse and you do it as a package, and you
Yeah.
do for all these kind of cases who come to you with the previous poor quality embryos or arrested embryos. So what is it that you have noticed which is which is like a significant thing when you put the embryos on time lapse?
See, I will go back to the first thing again. I think what is the thing which changes the outcome is standardization of drugs. Trust me on this. Okay, standardizing the drugs gives a beautiful stimulation outcome to majority of the patients. Doing your ICSI with as minimal exposure, uh, your plate has to be covered with oil nicely, and the exposure time of the oocyte per ICSI has to be very, very low. Okay. If in case you are able to do the whole ICSI in approximately 1 to 2 minutes, even if there are 10 to 15 eggs, which you will normally do, right? That gives rise to a slightly better outcome because the exposure is so less at that stage. On the time lapse, I think the best thing which you start seeing, again, I'm saying, is that once the fertilization has occurred, you will see 2 PN stages beautifully. We've shown it so many times on the time lapse. But the division of blastomeres, it gives you that earliest prediction as to how which embryo will go where, you know. And that I think, okay, is one of the biggest advantages because these people are anxious. They will call you on day 3, sir, mera embryo bana kya, you know, and you will be in that situation to tell कि, okay, I think, 2 might go till blastocyst. That is a very reassuring thing for these couples, is what I have seen over the last 5 years, because I have time lapse since 5 years. Apart from this, I personally don't think it really adds to the success rates. Very honestly, I just think it adds to that feel good factor, and patients feel very. I mean, I don't know the English way to tell it. They feel
Confident
very
about.
happy about your honesty.
Yes, yes, yes. Confident about you as a consultant.
Yeah.
Okay, so they have had poor embryos in the previous cycle and they come to you and they form good embryos on day three or day five. And do you still go ahead with freezing, or it is like it is immaterial? I mean, as your usual protocol is about freezing, and you
Just
just go
freeze.
ahead and do it, or do you
Yeah,
like?
just freeze. Every egg is different. Every embryo is different. Just freeze it if it is day 5. I mean, and if your cycle is a frozen cycle, no need to do a fresh transfer.
Do you think the trigger matters in this situation? Like, have you noticed that retrospectively, when you give a certain trigger, like the quality of the embryos are poor, or is it only in getting the oocyte the trigger that is where it ends and nothing else matters
It,
about?
honestly, forming embryos is an oocyte dependent game. So if in case you are really so worried, you should use better drugs for stimulation, better protocols for stimulation rather than worrying about the trigger. Trigger is going to be something which is going to, of course, give a big difference. Okay, but I mean, it does not really only do qualitative justice. It also does quantitative justice. That is why triggers are to be given nicely. But if somebody is, again, as I said, worried about, if you want top quality embryo, you give top quality drugs. It is simple. You can't put water in a Porsche engine and ask it to run at the speed of petrol. All that doesn't happen. You have to put petrol, the car will run on petrol. Okay, simple.
How can you say that? Okay. So tell me this. You told about the stimulation. Why are you stressing so much upon the stimulation drugs? I mean, aren't we all aware that this is the most important factor contributing to the success of the whole cycle? And don't
We
you
are
think?
aware, but sometimes in a country like India, economics also play a very big role in our awareness, and puts many things on the back seat. See, one extra oocyte you get out of one good quality stimulation protocol which you have used. gives you that potential of converting that cycle from forming no embryos to forming one top quality embryo. That's the amount of difference it creates. So, as I said, I have been a very strong proponent of uh, using good
Okay.
drugs.
Yeah. So if you are so very like, I mean, do you check the batch of the drug? Do you make a note of it? Do you like, retrospectively analyze? Do you audit your cycles? And do you say that this batch had a good response, this batch didn't have a good response? Do you change the batch when you don't see three, four patients not responding on day five of stimulation or day seven of stimulation?
Madam, we make our batches, so we don't really end up changing the batches for most of the
Forget about
times.
you. Yeah, forget about you for general people. If you can please tell.
No point, no point checking the batches because these batches and QAQC, I mean the bioassay report which is provided out of these batches is,
Okay.
uh, yeah, it is beautiful. But one must understand that there is absolutely no correlation of all that. Okay, it really depends on how these drugs are then transported to your place, how you store it in your place, and I think that matters.
Okay, then like, I mean, there should be no poor quality embryos or arrest if we are using Rec FSH, say Recagon or Gonalef, or if we are using Menopure and who we are like, 100% sure that the quality is like top class. So you think, I mean, that is how we should go ahead in such cases where we have to just stick to that one particular super quality drug which everybody like, vouches for?
That is being very ideal. But remember one thing, even if you use the most ideal things, then there is a patient factor. Here I'm trying to talk of things which are not used, and then when you standardize it, you start getting outcomes out of it. So as a referral unit, almost every month we will get around 30 to 40 patients who have not formed embryos. Okay. The next best thing which happens in our country is that, Acha, you did not form embryos, very bad. Now go ahead with donor cycles. Patient will stop the stimulation, patient will look for options, and when this patient comes to you, you will find this little thing which has gone wrong. You just change that little thing and patient will form four embryos. Okay.
Yeah, we have seen
So I'm
that.
talking for from this perspective. I am not trying to tell you that if you use let's say menopure, everybody will form embryos. That's not correct. I'm trying to tell you that your chances of forming top quality embryos goes up drastically when you use top quality drugs. That's all that I'm trying to tell you.
Yeah, I agree. I completely agree with what you're saying. So, yeah, I think, so do you think embryologists matter in such situations? I mean, are they like, because they are the heart of the IVF, the whole system. So you think the competency of the embryologist really matters in such situations?
Madam, tell me one thing. If you are India versus Australia, okay, and you need 100 runs to win in 15 overs, okay, and you have four wickets in hand, you think that Mahendra Singh Dhoni is a very good option to send as compared to Jasprit Bumrah,
Yeah.
right? Right. So you agree to that, correct? The same thing is with the embryologist. The game is in the skill of that particular embryologist or biologist as to how well he is handling those gametes. Okay. If the handling of the gamete as per protocol is good, the injury, the stress on that gamete is very less. If the stress on the gamete is less, the gamete saves a lot of energy, okay, for reserve rather than fighting the free radicals which are generated as a result of incorrect handling. Correct? When that happens, the way in which the gamete can proliferate and allow for development of, division inside it through those mechanisms of separation of the chromosome, all the energy is used there. Okay, and that is why a good embryologist gives rise to a good embryo. Simple.
Yeah. So our embryologist, I mean, he vouches for IVF than ICSI in such
Yeah,
situations where he does 50% IVF and 50% ICSI. And we have had
correct.
excellent results with that. So
Yes.
you think, see, to combat that factor of ICSI technique and
Yeah.
the subjective problem that we will face in cases of ICSI technique, especially freelancing embryologist if they are called for and things like that.
Yeah.
You think IVF still has a role in the current scenario of IVFs where everybody and everything is like, pushed in for an ICSI?
See, madam, nature is the best embryologist. Okay. And in IVF, you're relying on nature to do the embryology work. Correct? You only have to prepare the sperms. You have to aspirate the oocyte with the sperm and reflush it out inside the droplet. Correct? Rest of the work will be done by God. Okay. So if I think definitely there is a role of IVF. I mentioned that as the first thing. When you have fertilization failure, that is the first thing which I mentioned, in fact. Correct?
Yeah.
But uh, but you must remember that IVF should ideally be done in women. Let me just put it this way: IVF should be done in not in unexplained infertility. IVF should be predominantly reserved for cases where embryos have not been formed and there is a very strong, slight male factor or a tubal factor.
Mm.
Okay. In that, if you do IVF, you'll get excellent outcomes.
Yeah.
I don't think IVF should be done in unexplained infertility because in unexplained infertility, oocyte factor is a major compromise. So despite sperms and everything being done nicely and despite IVF technique being correct, okay, there could be something which has gone wrong in the zona, let's say, which causes a fertilization failure.
Mm. Yeah, true. Yeah, I think so. Do you think the oocyte pickup technique also matters in the embryo quality? I mean, just as a completion, I'm just asking this question.
As long as the oocytes are coming, drop, there is no problem. You know.
Oh, come on. I mean, it's not.
Otherwise,
No, be
I
quiet.
mean, what I meant to say is that as long as the suction pressure is correct, right, somewhere between 120 to
But
150.
you wanted to see our oocyte pickup technique when you were here in Bangalore. I mean, I was wondering why. I mean, it is universally the same thing. What is done
No, no,
every.
no, it is not. It is not. It is not. It is not universally the same, but yeah, if you standardize the pickup, if you go right in the center of the follicle, as we've shown multiple times, if the manipulation of the needle is minimalistic, if the pressure of aspiration is correct, if there is no double flush, whatever, in all these situations, usually the injury to that COC is very less. Okay. And when the injury to the COC is less, the damage to the oocyte is less. Simple.
Mm, mm. You think endometriosis, see, pre-surgery, sorry, not pre-surgery, endometriosis being associated with the fertility issues, and you go ahead and do an IVF without doing a surgery by just giving, like, medications like Dynogest and Lupride, and then try to form embryos, and we see that the embryos get arrested or they don't go till blastocyst. So you
Yeah.
think in these situations, these can be corrected by
Yeah.
correcting the root
Just
cause?
do the nice surgery, correct the anatomy. You will take care of 80% of the abnormal hormonal milieu in the peritoneum. Next time you do it, you will get a better outcome.
Yeah. Okay. Yeah. Thank you so much. I think it was wonderful. It was really, really, I think I could not find much of literature, to be honest with you, regarding this topic. And I should agree that, like, when you said that this is a very interesting topic, it really came out very well in today's class. I think all of us are very grateful for you to come up with that, the flow chart as to how to deal with it. So thank you very much. Good night. I think you must be tired. Thanks.